Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Surgeons often feel powerless to make change in the systems that we work in. But as Dr. Andrew Furey says in this episode of Cold Steel, the key to change is to just do it. Dr. Furey is an orthopedic surgeon at the Memorial University of Newfoundland. He is also the new Premier-elect of the province of Newfoundland after winning the Liberal Party nomination on August 4th, 2020. In this episode, we hear about how Dr. Furey started Team Broken Earth, a humanitarian organization, his work with Team Broken Earth in Haiti, and his thoughts on leadership and physician advocacy. Dr. Furey, thank you so much for coming on Cold Steel with us. We really appreciate you coming on, especially during these very uncertain times. I know many of our listeners will know you well, but for those who may not, can you tell us a bit about where you grew up, how you ended up in medicine, and why orthopedic surgery, and what made you stay in Atlantic Canada as a faculty surgeon?
That's a pretty loaded question. That's multiple parts to that. But first, thanks for having me on. So I grew up in St. John's, Newfoundland. I actually did a fairly liberal undergrad degree. Wasn't sure what I kind of wanted to do in life. I was drifting towards medicine, but come from a family of teachers and lawyers, and was also kind of keen on that. And so I applied to both medical school and law school, got into both, and then took the leap of faith into medicine. Decided to really study medicine. Decided to stay at home to study medicine. And as I was doing my undergrad degree, I realized that I really enjoyed the surgical specialty pretty early on. Was attracted more to the anatomy than the physiology, so to speak, and from there discovered that I was really keen on MSK. I'm not the typical kind of orthopedic surgeon. I'm not the kind of jock who was on every sports team in high school or anything like that. I never had really any exposure to orthopedics, but was really attracted to the biomechanics and the immediate difference you could make in someone's life. You could see an X-ray, you could see the problem, you could articulate the problem, you knew what the problem was, and then you could articulate and execute on a solution, and then see the fruits of your labor in short term. Seeing someone who was involved in a motor vehicle collision with a femur fracture, who was not able to walk in traction, and then 24 hours later was walking on the ward. It was pretty powerful for me, and that led me down the path of orthopedics. I was always attracted to the fracture side of orthopedics, even as a clerk and medical student, and that continued. Orthopedics has a lot of incredible careers to offer, but I was really still attracted to the excitement of trauma, and that led me to a fellowship in trauma, in shock trauma in Maryland. And myself and my wife were living there, and we had actually entertained taking a job there. I actually had taken a job my wife came home one day and just said, "This is too busy. It's too crazy. Let's try to find it." We had just had a baby. She said, "This is an incredibly dangerous city. There was a cop shot in our neighborhood, and was working all kinds of crazy hours." And she said, maybe it's best if we move back to Newfoundland." And so we did, and set up shop here in Newfoundland in 2007. And even though she's a come from away, I couldn't get her away from here, even if I tried.
That's awesome. Yeah, shock trauma is a really interesting place, both on the orthopedic side and the general surgery side. It's an incredibly unique institution.
I feel incredibly privileged to have experienced it. It is a truly special place, full of special people. It's very humbled and honored to have been able to be there for a year. It was truly, truly amazing.
Yeah, it's amazing as Canadians, again, whether it's orthopedics or general surgery, urology, whatever that is, heading down to the U.S. to some of these incredibly high volume, unique, and a little bit rough, as you point out, experiences. A lot of our country is, at least on the trauma side, injury side, is trained in the same way with sort of similar experiences. It's quite neat.
Yeah, I mean, and as you know, it's a standalone. At the time, I assume it still is standalone. It's the only standalone trauma facility in the whole country. So you couldn't, you had to meet a certain injury severity scale to get in through the doors. I still don't think people believe me here in my local colleagues when they say I didn't see an elderly hip fracture for a full year. I didn't.
Yeah, exactly.
We never used cement. I never saw any joint replacements. It was all young people who were involved in a trauma, had multiple injuries. I think I forgot that towards the end of the fellowship, I think I forgot that there was that you could have a closed injury. Everything was an open fracture. Everything was an open fracture. An incredible place to live for a year, an incredible place to work, incredible people. Just the amount of experience you can get in a year is phenomenal.
Yeah, it's mind-boggling.
Yeah.
Yeah, I mean, there's the list of those kind of jewels for all of us is short, but wow, are they impressive. And, Andrew, one of the things that we all know you very well across the country for is your tremendous and the longevity and the intensity and the success of your interaction with global surgery. And I guess the vehicle or the moniker that we mostly know is Broken Earth. I'm sure there's others as well that you've been involved with, both in the past and present. But we're curious, what prompted you to create Broken Earth over the years? Can you describe it to us? And in particular, I wondered what those initial days looked like when you were trying to set it up and trying to get it moving.
Sure. Yeah. I mean, so the kind of serendipitous or the different portion of this kind of adventure has been that, in medical school and residency, global health was never really on my chip. Like it wasn't something that we kind of grew up talking about at the dinner table. I had known some medical student friends who had gone to Uganda and other places. And look, I was their biggest cheerleader, but I was never really thought that it was something that I would end up doing or being a part of my life. And then when we came back from this high-powered fellowship with lots of trauma, I was still keen to try to find ways to keep that level of energy and adrenaline up, but never really found something. And then, fast forward a few years, and the earthquake happens in Haiti, and sitting in my living room and watching the images coming in live of the collapsed buildings and the human despair and destruction, and it kind of hit me that people were gonna die or had died of their general surgery injuries, their neurosurgery injuries, but they weren't necessarily going to die of their orthopedic injuries. And maybe I could find some way to help. And so I volunteered initially, then with a group out of shock trauma to go down as a part of a crew of people operating in a partially collapsed hospital in downtown Port-au-Prince, and it was life-changing. I mean, that's the bottom line. Standing amongst all the rubble in this kind of MASH unity type of hospital, it was one of those moments where you either say, okay, I can check this off the list, and I've been there, done that, or been there, seen it, and there's so much more to do. Let's try to do something bigger. So when I got home from that first experience, having never done anything like it before, I was fundamentally changed, and I wanted to do more. And part of being a part of a team from the United States mixed with all kinds of different people from all over, I felt that there was a way that we could improve on the efficiency of that model by by just going with people that you know and trust. Because like anything, if you're mixed with a group of people and you're thrown into a chaotic situation, you still don't know their names. You're trying to remember where they're from. You're trying to you're trying to figure out if you can trust them, because as we all know, not everyone in medicine who says they can walk the walk can.
Yeah.
And but I thought, like I know my anesthesiologists here, I know my plastic surgeons here, I know my nurses here. Like, why can't we just kind of take a group of 30 of us or whatever from Newfoundland and Labrador and go to Port-au-Prince? And then I know I can trust them. I know what they can do. And so that's how the kind of concept began. It really kind of started over a cup of coffee in the OR lounge with two guys asking me about the initial experience in Haiti and wondering if they could be involved if we ever decided to go back. And up until that point, I'd never really thought about really, truly kind of going back. But right after the trip, people started asking, and then I thought, well, maybe we can put together this team, and this was only supposed to be a one-off. It was supposed to be, okay, we'll go down with one team, and that'll be Newfoundland and Labrador's contribution to the relief effort in Haiti. And it was just a total fluke that we put a name on it called Team Broken Earth, because I felt like people would want to feel like they were part of something, and we just to say Team Newfoundland didn't really make any sense, So we went down, and it was a team of 27 or 30 of us initially, I think, and operated out of a hospital in downtown Port-au-Prince in the red zone, which is one of the most violent areas in a violent city, and made a real difference to a lot of people, and started to build some relationships there. And I really, on the plane ride home, I thought, oh, that's pretty neat. We just did some cool stuff, and we should all be proud of that. And but I wonder if there's anything else to this. And within minutes of landing, my BlackBerry had just been totally lit up with, nurses and doctors and physiotherapists all saying that it was one of the best things they've ever done. They want to go back, and when can we go back, and let's go back. And so there was another kind of epiphany moment of, well, maybe if Newfoundland and Labrador kind of sends two teams once a year to Port-au-Prince, we could have a regular rotation. We can develop relationships. We can start to think about education. We can start to have a continuity of care and start to build a program. And so that's kind of how it started. And then, believe it or not, the rest of it is a lot of just word of mouth. Paul Duffy from Calgary, an orthopedic surgeon who I trained with, excellent guy. One of my, I consider him one of my best friends, even though there's a geographic distance between us now. Was here in Newfoundland playing a hockey game, an annual general surgery versus orthopedic hockey game that we have here every year. And orthopedics, of course, has to win every year, so it's not. We will fly people in, ringers like Paul, to make sure.
I love it. I love it.
And so we were in a dressing room and chatting afterwards, and Paul saw the Broken Earth emblem on the hockey bag, and said, what's that all about?
That's
started telling him, and he said, well, I think we could do that in Calgary, and Calgary was the first kind of jump off where, well, Newfoundland and Labrador, we're only 500,000 people, and everyone's taking their vacation time. Like 2 teams a year is probably, that's more than we could expect. But if everyone in Canada started to do a little bit, then all of a sudden you have a real program, real continuity of care, people offering different skill sets, building different relationships, and building true capacity in particular in Haiti.
It's interesting. I didn't realize that the Calgary group was so early, because when we went down, it felt like it was pretty well oiled. Like it felt like everything was smooth, and there was no big hiccups, at least up front. I didn't realize that. I'm sure there must have been some pretty significant challenges for you. Just setting it up moving forward, in particular, maybe with the communication and the relationships on the ground there and with the locals. Is that accurate?
Absolutely. I mean, the challenges, the hurdles, and the barriers that we've overcome they seemed immense at the time, but it's funny, you know, like thinking about them now, they're hard to remember. You know?
Right.
I mean, there was many crossroads, whether it's the first trip or, you know, the second or third, we kind of thought you could have put your tools down and just said, this is too hard. Like, oh, there's no way we can overcome, I don't know, the travel insurance or the finances or whatever. And we just kept pushing, and initially it became frustrating, but then you kind of just accepted it. If you kind of got over one hurdle, you knew there was going to be another one just around the corner, and you try to deal with that as best you can and move forward. But initially the relationships, I think that, you know, I talk about Broken Earth a lot around the country and in the United States, and I think what makes us a bit different than some other organizations with respect to Haiti in particular is that we have committed to this one entity, and we built those relationships so that people can leverage what relationships we have built. And I think if you were going to set up your own Broken Earth and call it something else, like, you would find the money, believe it or not. You would find people who do it with you. You would find a location that would take you, but the hurdle that is the most difficult to overcome, and it's only because we've been at it for 10 years, is the relationship and the trust that's just been built over time. And that's what that's kind of the added value that we kind of bring to the equation.
Yeah, makes sense. You wrote a really great paper in the Canadian Journal of Surgery about the 2014 Haiti Orthopedic Trauma Symposium, and it's, you know, the concept of legacy or of sustainability, of leaving, you know, maybe as much as you take from it, is something that you've talked about. It's something that is ingrained in Broken Earth, I would say, as a culture. Can you talk about that paper and what that goal in terms of the conference was, and your view of sustainability?
Sure. Yeah. So we've evolved from being like just entirely clinical initially, and I think that was obviously that was what brought us there in the first place in terms of an earthquake. But then it became immediately evident that, you know, we needed to shift to an education component if we're going to make an impact long term, because you can treat one femur, but if you can teach someone how to treat multiple femurs, then, you know, then that should be the ultimate goal, and the ultimate goal should be to work ourselves out of a job down there. So we quickly pivoted to an orthopedic, as an example, as an orthopedic trauma symposium. And the symposium we've done 5 times now, and we've been on hold for the last year, initially because of instability and political instability down there, and now because of COVID. But what it is it's a series of lectures put off by Canadian orthopedics and U.S. orthopedic surgeons from across 2 countries. We bring all the orthopedic, or as many orthopedic residents as we can, in from around Haiti, including subsidizing their travel from up north and bringing them to Port-au-Prince. And we do a series of lectures on fracture care, and then there's a series of labs that have saw bones, fake bones, where we fly down, you know, hundreds of thousands of dollars worth of equipment, and then the residents are able to practice in the lab about how putting plates and screws on bone. Wow. with under the guidance of the Canadian and U.S. surgeons. And I mean, we always knew that it was building capacity and that it was teaching people, and that would be a true legacy. But I tell you that the one of the most proudest moments for me in all of this was in the craziness of running one of these courses, the last course in particular that we ran. You see the guys and girls who were the junior residents on the first iteration of the course are now in PGY 5, and they're helping teach other residents at the tables at the lab.
Amazing. Yeah, amazing.
And you kind of know that you've kind of really made a difference. And it's that was pretty cool aha moment. Even though you hopefully you could have predicted it coming, you never know. But to see it firsthand was pretty special. And in terms of building capacity, we did do something good initially. A lot of what we've done has just been by fluke, but as we started to grow, I felt that it was really important that we concentrate on what we wanted to accomplish and look inwards about what our core competencies want to be. And because you can imagine as you start to grow, you can go off in all different directions pretty quickly, and it could get out of control pretty quickly. So we have always kind of concentrated on clinical care, education, infrastructure, and relationships, and that's what we want to build any team around. And so in terms of building capacity, education is an incredible piece. Obviously, relationships are critical, and the infrastructure is important as well. And so we've built a new hospital down there, probably since you've been there, a new hospital wing within the confines of the space and the footprint of Bernard Mabs. It's 2 stories, effectively doubles the capacity of the hospital, and I think that's a pretty cool legacy piece that, even if for whatever reason, political instability, global pandemic, whatever, we're never able to get back to Haiti ever again. The education and the education that we've left and the infrastructure that we've left them with is, I think, is a pretty significant contribution to the Haitian healthcare system on behalf of all Canadians.
Not only have you done a lot of work globally, particularly in Haiti, but clearly you have an eye locally and have been active in trying to understand the problems that affect Canadians. And we wanted to highlight another of your papers in the Canadian Journal of Surgery, talking about the morbidity and mortality from pelvic rami fractures in elderly Atlantic Canadians. Traditionally, I think we don't think of pelvic rami fractures as being a particularly morbid or serious injury, but your study kind of highlighted how different that might be for an elderly population. Can you talk to us about your study, and how do you think we can prevent some of these injuries within our more vulnerable populations, particularly in the elderly?
Yeah, so myself and Chris Hamilton, who's a surgeon, he was a resident at the time, were chatting. I was his master supervisor, and they were chatting about different projects. And one thing that had always struck me was we fix all these, an elderly person falls from a standing height, and one of 2 things happens. They either break their femoral neck or their intertrochanteric hip, or they have a pelvic ring injury of some sort, usually the pubic rami with some sacral injury in the back. But we totally ignore the pubic rami and pelvic ring injury, but we fix every single hip fracture. Surely there is morbidity and mortality associated with the pubic ring that we're just and the sacral fracture that we're just ignoring or don't understand or hasn't been a part of our treatment algorithm. So we kind of looked at that, and it definitely plays an impact, because it's the same as if it has an impact. Because if you don't treat, the same as treating a hip fracture non-operatively to a certain extent, you've committed them to bed for a certain period of time. They're already generally have multiple comorbidities with limited mobility. So it was really supposed to be a paper evaluating that and looking forward to potentially, should we be thinking about treating some of these surgical so that they can mobilize faster, so that they can get back on their feet more and prevent any post-injury complications from happening. There's no question that, you said the elderly are some of the most vulnerable in society, and they are. And we've even looked at, we've done another paper with looking at the rates of even surgeon understanding of elder abuse. Everyone appropriately talks about intimate partner violence, and we're part of a big study on that as well. But there is an element of elder abuse that I think that as society we are probably missing. Not probably, we are missing. And I think that as surgeons, we need to shift our attention towards that as well. because they are, and I think this COVID crisis has certainly lent a different lens to how vulnerable our seniors actually are, or even at home, and we need to do a better job in protecting them and making sure that they're able to live their last years as some of their most fruitful years.
Yeah, that's so true. I mean, just this month, my last week on our trauma service, we were talking about this exact thing. It's funny it comes up, but we are clearly, underdiagnosing or underdetecting elderly abuse. It's clearly going on at a much greater level than I think we appreciate. And sure, we pick up the most exotic or bright, cases, but we probably need to do a better job of screening our elderly.
Yeah, even if you assume that there's I don't know, 2% or 3% for the fractures that occur in an institution in particular, or rate of elder abuse. Like, I can tell you, I've never, and I don't know of many that have.
Yeah.
Identified that in a fracture clinic or in a hospital setting, because for all the reasons, right? But maybe we need to be better at developing a screening tool to direct our attention towards it.
Yeah, for sure. Andrew, we promised we wouldn't ask you any questions in particular about your foray into maybe your next job, but I did want to dance around that a little bit and ask you what your view of the concept of leadership was. Ask you, some of the roles maybe that you've played beyond Broken Earth in terms of leadership, and whether that's in your hospital or even before that. I was just curious on your viewpoint of that concept, because it's a pretty obviously broad 30,000-foot term, leadership, but people interpret it in very different ways.
Yeah, I mean, I've always looked at leadership as I've never looked at leadership as a command and authority kind of type of leadership style. I've always looked at it as you need to figure out the right tools to engage people, empower them, and help navigate them through complex, often difficult situations. But you can only do that if they believe in the vision and the direction in which you're going. But you need to support them, empower them to make their own decisions, and to follow you into an unknown situation. And I don't think you can do that with the command style leadership, that really authoritative, follow me because only works for short periods of time and in very trying situations. But if you really want to move and engage a team of people to follow you, then you need to make sure they're empowered, engaged, have an understanding of what you're trying to do, and motivate them to perform. And so that would kind of be my 30,000-foot view. I mean, there are all kinds of different leadership's become almost a science, or tried to become a science, in terms of different papers. Looking at the different elements of leadership and the combination of cognitive and emotional intelligence. But at the end of the day, it's about the people that you're trying to engage and lead. And if they believe in the vision and they believe that they can make a difference, that they're not just part of a train that's going along anyway, then I think that's the style to employ when trying to motivate a large group of people.
Yeah, it's so true. We had a great conversation on Cold Steel with a gent by the name of Phil Daw, who you may or may not know, comes from a very proud military family. He's a general surgery trauma surgeon out in Vancouver. And really the hour or close to it surrounded the concept of leadership. And I think, certainly listening to Phil and in contemplating it, the contemporary definition of leadership really surrounds exactly what you say. It's maybe less of a hierarchy, it's less top down, and it's much more engaging at the so-called grassroots level. So I guess my question then for you is, how do you do that? How do you whip up personal investment in folks as you try and move the whole bus forward on whatever that given topic is? hard.
That's the age. It's easy enough to write these things down, but the how is always the
right when the rubber meets the road. Totally.
Yeah. I think I think it involves a lot of trust in people, but here and trust is obviously incredibly important. But you also have to trust them to fail, and it's okay to fail. And I think if people have some ideal notion of perfection at all times, it won't work. So if you empower people on your team to make decisions, to take pride in those decisions, but that it's okay if at some point inevitably there is a bad decision, or the outcome isn't favorable, then I think it allows them to be more creative. It allows them to be more engaged. It allows them to take ownership. It allows them to feel like they're actually helping steer the bus as opposed to being a passenger on the bus.
Yeah, for sure. It's an interesting time in Alberta right now, and we certainly won't get into the nuances of what's going on here politically and with the healthcare system. But I was just curious on what your view is as to how best physicians can advocate both for physician wellness, but certainly more importantly, I think for patient wellness in a balanced, responsible way, recognizing that certain areas are tougher than others and so on. But how do you view that relationship in general?
Yeah. So first of all, I wouldn't say more importantly for patients. I think patient wellness. Obviously, we're bred to be patient advocates, and we would never get rid of that element of who we are. But I think we've done a terrible job at being our own advocates to date. And part of that is just total culture. I really worry about physician burnout and a lack of balance between the old school of being in the hospital 24 hours a day, 7 days a week, and trying to find a balance with life as we know it. I think the generation just below me in particular is excellent at pushing that work-life balance, and I think as physicians and physician leaders can never lose sight of how important that is, because a burnt out physician is no good to anybody and bleeds into terrible patient care ultimately. So you'd rather have a physician who's engaged, who is not burnt out, who's ready to go, who loves the job, loves every moment of the job, is truly passionate about it. And I think preventing burnout and maintaining that passion and empathy and compassion is incredibly important in both in terms of the profession and looking after patients. I also think that physician leaders are often afraid to step. I mean, we're all great at pontificating in the OR lounge about how things should be, right? But a lot of us, many of us, are afraid to be a part of the political system. And my father would always say that if you're afraid to put your hand up at all or engage in the process at all, then your voice doesn't matter. So, I mean, I think there's a growing number of us around the country, in particular in the last 5 to 10 years, who have recognized that being part of the political process, and that doesn't mean putting your name on a ballot, by the way. That means there are all kinds of other ways to be involved in the political process is incredibly important, because we can sit and dump on politicians all we want, but they're the ones who make the decisions, and they're not making the decisions in some sort of echo chamber, by the way, they're trying their best, presumably, to listen to all points of view and to make the decision. So if you don't have a voice at that table, they're not going to hear it, and then they're not going to make a decision that, of course, you're going to be upset with their decision because you haven't adequately influenced how they're going to make the decision. So I think it's important. I think it's important to recognize that as doctors, we don't live in some sort of isolated silo. That we, if we want to progress the patient advocate agenda, or our own agenda, we need to have a voice at the table, and sometimes that means taking a role in the political process, because that's how the system works. The elected officials help direct the agenda and of the province and of the country, and if we want to change that agenda or help it pivot, then we need more than a voice in an echo chamber that is the OR lounge or the coffee lineup or wherever.
Your comment, Dr. Furey, about people complaining about politics and the situation and the system in the OR lounge rings true for anyone who sat in an OR lounge for any period of time. For those of us and for our listeners who might actually be interested in getting more involved, whether politically or even locally in their hospital, what advice would you have for those folks who are interested in getting a bit more involved?
Just do it. Yeah, I mean, there are all kinds of different ways to be involved within the leadership of the hospital, leadership of your residency program, and then within the political system itself. I mean, like I said, you don't have to put your name on a ballot to try to influence the process. Or influence your elected officials. And by influence, I mean in a good way, right? I'm not talking about like lobbying or anything like that. I mean, just that's the way democracy works. You put forward ideas, and whoever's ideas are the best get elected, and or that's the ideal notion. So if you're involved in helping shape those ideas that are being presented, then you can really change the way your province or your country looks. And so I would suggest, if anyone's interested, there are physician leadership courses available. There's even I think a political program within the Canadian Medical Association, which allows you to help talk to your MPs and others through some. I'm just drawing a blank on the name of it right now. Or if you're so inclined, help out with the next election campaign. It doesn't matter the party really or any of that. It just matters that you're involved. Because once you're involved, you get a better understanding for how the process works. You get a better understanding for how you can help shape the process, help influence the process, and ultimately help lead to decisions that you think are best for the people of your province and your country.
Yeah, I think it's just that initial leap of kind of putting yourself out there that unnerves a lot of us, and particularly trainees.
Yeah, but I mean, you don't, like you said, you can just volunteer on the next, your next Alberta provincial election, for example, or be a part of one of the parties there where your ideology is most aligned. I can tell you that they're always looking for smart people like doctors and people who understand the healthcare system to be involved, without a doubt, because we bring a unique perspective, a perspective that's not always seen as doctors to the table.
This conversation has been really fascinating, and it's been a real pleasure to talk to you, Dr. Furey. In closing, I just was hoping that you could give some advice that maybe you wish someone had given you during your residency, and I'm being a bit selfish here given that I'm just about to finish. So if there was anything that you wish someone had told you during residency, what would that have been?
I think the take-home lesson for residency for me, if someone could have articulated perhaps a bit better, was that the exam at the end is only the beginning. So don't put too much pressure on yourself for the exam. I mean, of course you want to pass, but really the true education begins after you start, because there is a whole other series of pressures and concerns when it is your patient, your practice, that isn't captured by any sort of examination process. And I think the shock of that, for me a little bit, and I think it's probably true for all surgeons if you're being honest, was a little bit more than I would have thought. So that would be one thing. The other thing I would say is, again, it's the same theme, but it's just the start, and you can do all kinds of incredible things once you're finished. I think you feel like you're in a silo. You're so concentrated on the subspecialty or the specialty, but medicine has incredible opportunities beyond the walls of the hospital, and you just got to keep your eyes open and keep looking for them. Whether it's being involved in global medicine or your local community, or giving back in a nonprofit, political, or any other realm, but don't be locked into the four walls of the operating room. Make sure that you keep your head up and look for opportunities, because at the end of the day, 10, 12, 15 years in, the job is still awesome and fun and love every second of it, but there are a lot of what's exciting initially becomes routine, and I think you need self-fulfillment from other opportunities as well.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.